So today we're very pleased to welcome George Robertson from the Dalhousie Departments of Psychiatry and Pharmacology in the Faculty of Medicine. Dr. Robertson's primary expertise is in the fields of neuropharmacology and apoptosis. He completed his postdoctoral training in the Department of Pharmacology at Dalhousie University under the supervision of Harold Robertson in 1989. After completing postdoctoral studies at the University of British Columbia, he became assistant professor in the Department of Pharmacology at the University of Ottawa and later associate professor in '96. Dr. Robertson has also worked in the industrial sector where he was director of the neuroprotection program for the biotechnology company Apoptogen Inc. And he was also the head of the Department of Pharmacology at the Merck Frost Center for Therapeutic Research in Quebec. Dr. Robertson's primary research interests are in the development of surrogate blood markers and treatments for psychiatric and neurodegenerative disorders. And today's talk is entitled Gene Therapy and Small Molecule Approaches for the Prevention of Cisplatin-Induced Hearing Loss.
Yeah.
It
There
matches.
you go. Yeah.
Welcome, Dr. Robertson.
Yeah. Thank you, Joanne. Okay, so I remember I was watching a program about somebody who was trying to grow lettuce hydroponically in Newfoundland, of all places, and had become quite successful. I don't know if he still is, and he was interviewed and he said, "So what's the secret to your success?" And he said, "Oh, I know 1,000 ways to kill lettuce." Well, I certainly know many ways to start companies, of which with almost similar results, I would say. And as we know, after 2008, at the dawn of the Great Recession, that if you don't have a business plan that turns over some sort of a return on profit in a couple of years, it's very hard to raise venture funding. Nevertheless, improvements in the viral vectors, or now they're really just called vectors, have made it possible to use a variety of payloads that seem to have interesting proof of concept, not only in animals, but also in people, in the case of Leber's disease, for example, and blindness. So I'm going to talk a bit about work that I've done in gene therapy and how I see the ear as an accessible and a useful organ in which to establish clinical proof of concept for hearing loss, and also small molecule strategies that might be used. And because these trials, especially for neurodegeneration, are very slow, they're very expensive, they're complicated, and they often fail, I've been thinking about, what would provide rapid proof of concept in the clinic. And cisplatin-induced hearing loss, which can occur very quickly within the first cycles of chemotherapy, particularly in children, might actually provide such an opportunity for proof of concept. And I'll finish up with talking a bit about that. So hearing loss is a huge problem. It's becoming increasingly so as our population ages. Overall, it's about 1 in 10. 1 in 3 adults aged 65 to 75 suffer from some sort of loss of hearing sensitivity or tinnitus. And we know that in the military that veterans had served in Southwestern Asia and Afghanistan, that hearing disabilities were the predominant problem. And of course, as that population ages and the natural attrition associated with aging occurs, then the hearing loss will become even greater for those that have some residual hearing. So as the population ages, the incidence becomes much greater, going to 1 in 2 at 75. Approximately 1 to 2% of school-aged children have some sort of hearing deficits, and 4% under the age of 5. And this is a real problem because it impairs social development in children and obviously educational development, resulting in huge loss of human capital. So, as I mentioned, social problems can occur particularly with children. They find it difficult to make new contacts, and essentially, stimulating the brain in a way that is necessary to develop in a positive aspect for interactions. And hearing loss, which obviously isolates people, they can't participate in conversations, is thought to be a major cause of depression in the elderly. Severe impact domestically on spouse, children, and families. work. There's much higher unemployment as you would expect in profoundly deaf individuals. And Australian studies have shown that profoundly deaf attain language at half the rate of normal learning. And in Australia, they achieve, I don't know if it's because Australians are more challenged, but on average, they would only get to a grade 3 education level. Obviously, no Australians in the audience. Development effects, emotional and social development, and processing sound difficulties are strongly linked, obviously, with learning disability. It's been estimated in the U.S. The costs for special education, lost productivity, and medical care amount to about $56 billion annually. So it's a big problem, and one that's going to increase with time. So I'm going to go over the auditory system very briefly so that it can orientate you towards some of the strategies and the problems that we're trying to deal with. So the outer ear, which you're familiar with, the auditory canal, sound waves converge on the eardrum, and then through a series of 3 bones, the malleus, incus, and stapes, will produce sound waves that pass through the cochlea. If we take a section through the cochlea here, the organ of Corti, which is actually the sound sensing device, is shaken as the waves move through the cochlea. The basilar membrane, which is located, is stiffer at the apical end, and therefore more sensitive to high frequency sound, and then becomes thinner as we move further out towards the apex, where it can sense low frequency sound rather. So there's a topological organization of sound sensation in the cochlea that's conserved through the spiral ganglia neurons that go to the brainstem and then further up to the geniculate body, and then provide a representation of sound much the same way for sensations for other senses. Tinnitus is thought to be almost like a phantom limb phenomenon where loss of sensitivity to sound results in the perception of sound in the absence of a signal. And as you may know, this is treated using a mirror in which the remaining limb is exercised, giving the sensation to the brain that the opposite one is being exercised as well. And that seems to provide stimulation that helps reduce phantom pain sensation. And the same thing with tinnitus. We know that classical music, for example, will help tinnitus, or simply getting a hearing aid will improve tinnitus in many individuals. So what happens is that with hearing loss is that the hair cells, which are mechanically activated ion channels, allow potassium, which is very high in the scala media, to move down and excite these sensory neurons that then send signals to the spiral ganglion neurons on. So death occurs with cisplatin, with noise-induced hearing loss, predominantly in these vulnerable hair cells and spiral ganglion neurons. So if we look more closely, you can see the cochlea section here and the canals that move along from the base to the apex. And within this region, the organ of Corti, which is shown in higher magnification here, we can see the outer hair cells and the inner hair cells. And these cells are excited by the shearing forces that are created with sound moving through the cochlea that will activate, they literally pull on these hair cells, which are shown because of the sericilia that occur in bundles, and allow potassium, which is in very high concentrations, to move down the gradient and set up an action potential that moves through the spinal ganglia neurons to the cochlear nerve. So you can see here how they were arranged. If we were to take a section through the cochlea, you can see the outer hair cells, and then they send fibers to the spiral ganglion neurons, which are essentially at the base of this tree, and then they move on out to the brainstem. So hair cells are arranged in 4 rows, the inner hair cells, and then the outer hair cells. And they're called so because of high magnification. You can see the bundle of stericilia, which are opened by the shearing forces through the tectile membrane, allowing the generation of action potentials. With physical damage caused by acoustic overstimulation, the shearing forces will damage the sericilia, but they will grow back again. However, the hair cells will not, because they're terminally differentiated. So this shows the organ of Corti here in the normal ear. You can see the spiral ganglion neurons located there. And this is after physical damage that can be either caused by acoustic overstimulation and noise damage, or even by ototoxic drugs such as gentamicin or cisplatin. You can see the nice orderly rows of the inner hair cells and the outer hair cells, and then the degeneration of these cells that occurs. So cisplatin is probably the most toxic drug that has ever been approved by the FDA. It was approved in 1997. And to the best of my knowledge, it's still a mainstay therapeutic for soft tissue tumors, head and neck tumors, for example, and also I think for testicular tumors, and may even be used in some cases of ovarian cancer that's refractory to other chemotherapeutics. However, it's concentrated in the kidney and in the cochlea because of the nature of the pumps that are found there, and often results in ototoxicity or kidney toxicity. In fact, my understanding is the way cisplatin is dosed is that they'll go up to the point where they see maybe a slight change in glomerular filtration rate and then back off. So they try to get the dose high enough that they're not damaging the kidneys, but they're still getting maximal chemotherapeutic activity. However, that often results in hearing loss. About 50% of individuals receiving high doses will develop tinnitus or hearing loss. And this is much higher in children, probably because the antioxidant defense in the cochlea is less developed at earlier developmental stages. And they can actually be, there are genotyping tests that can be done for susceptibility genes such as COMT, catechol-methyltransferase, which are predictive of the likelihood of complications resulting from cisplatin therapy in kids. However, if the dose goes up high enough, 90% of children will suffer some form of hearing loss. And the toxicity often results in premature termination of cisplatin that may affect overall survivability. Approximately 40 to 50% of human susceptibility to cisplatin-induced hearing loss is genetic. In Nature, Michael Hayden's group has published on susceptibility genes and looked at their contribution to cisplatin-induced hearing loss. And I mentioned that there are two variants which seem to have a high effect on this, catechol-methyltransferase being the one that's best known, but they're both methyltransferase genes, the sulfur-containing genes that probably bind cisplatin. So simple genetic tests can be used to pick out these variants and to identify those individuals with high risk, which would be opportunistic if you were doing a clinical trial and you wanted to load the groups with patients that were most likely to be affected. So within the ear, cisplatin will damage primarily the hair cells and the fibers of these cells. So that's shown here in this level through the cochlea. You can see the fibers that are coming from the outer hair cells, which are lost in towards the cell bodies disappear. This is a section here. In green are the outer hair cells and the inner hair cells, and red are the fibers that go to the spiral ganglion neurons. And then this is after exposure to cisplatin. You can see how both are lost. So we became interested in this actually just before this paper was published, as often is the case, in which they showed that AAV-mediated delivery of a caspase inhibitor, this is an endogenous caspase inhibitor, X-linked inhibitor of apoptosis, in which they showed that injection of this viral vector encoding ZIAP reduced the ototoxic effects or the damage produced by cisplatin in rats, as well as hearing loss. The problem with this procedure is that they did the injection directly into the cochlea, which results in damage. So penetration through the round window membrane to get access to the cochlea. This is a very high impedance structure. There's not a lot of give. It's a hard shell, essentially, and the pressure increase and the damage associated with that would, in humans, be unacceptable risks for using this procedure. But it was fine for proof of concept. And what they did find, of course, was that they got protection. So we thought, well, there must a new procedure is required because adenoviral vectors do not cross the round window membrane, which is a thick membrane that is one of the main access routes into the cochlea. So we needed a way to try and get through there. All current methodologies use a very invasive procedure. Sometimes there was a recent paper I saw where they were injecting N-acetylcysteine directly into the cochlea. N-acetylcysteine is an antioxidant to try and reduce the ototoxic effects of cisplatin. And they did get effects which were they were quite remarkable in terms of protection, but obviously it's not a very appealing way to try and protect that organ. So our method, in which we have discovered a way to improve the diffusion through the round window membrane, is quite simple. This is company logo, and I apologize for that, but the slides were taken from things that I use for pitches. The point, though, is that it's possible to do this in a reversible way, so you don't damage the ear, and that enables the viral vector to get through and get into the cochlea. And so once inside the cochlea, AAV Zyac is able to transfer genetic information to the vulnerable cells where it's transcribed and translated into Zyac, which is a potent anti-apoptotic protein. And we know from the previous work that it does prevent hearing loss by preventing the death of these cells. So one of the strategies that we've used to try and improve infectivity is to use a viral vector that was provided by Bill Hawesworth. So Bill has been working with a large gene therapy unit in the University of Florida, where they have developed a series of mutants in which they have mutated the tyrosine surface residues to alanines. And what this does is it improves the life of the viral vector by reducing its degradation. So with the traditional vectors, what would happen is that after the adeno-associated viral vector was taken up into the cell, the surface tyrosines could be phosphorylated by EGFR, or epidermal growth factor receptor protein tyrosine kinase. And once that's phosphorylated, it results in ubiquitination of the capsid and is segregated by the proteasome. And what Bill's shown is that simply mutating some of these surface tyrosines, I think the one we used was this particular mutant Y730, increases infectivity by 100-fold. And this obviously is an advantage because it's not easy to grow these vectors at high titers. So this shows quite simply the way we'd imagine this being done in people. So you have basically a gel foam that's packed with AAV that will be put against the round window membrane after we had exposed the round window membrane to collagenase. So just a small amount of collagenase that produces a mild degradation of the round window membrane is sufficient to allow AAV to get into the cochlea. Now, why would this be beneficial? Well, the previous procedures I've mentioned, injection is invasive, whereas we would use a permeating gel that contained the collagenase, and then later on the AAV. It'd be very simple to do as opposed to a complicated surgery. You could probably do it in an outpatient setting, not requiring a sterile operating room, or experienced surgeons. Just using qualified personnel would be very inexpensive, and there should be a lower risk of infection than having to directly inject into the ear. So this is the view of the eardrum. So what would happen is that there would be a small cut or a myrigotomy that would be done close to the round window membrane, which heals up quite nicely, and then that would be rolled up much like a blind over a window. And then once inside the ear, it would be possible to get access to the middle ear. So the incision, and then once the incision is performed, we look inside. We now have access to the cochlea. We would put something connected to the round window membrane, each such as a gel foam, that would then allow us to deliver what we wanted to put into the inner ear. And then after a few days, the myrigotomy would heal, and presumably things would go back to normal. So here's an example of a viral vector that we used. This is an older version that didn't have the tyrosine mutant, but was expressing GFP as a reporter gene to see how well it worked. So you can see here, this is the eardrum essentially. and this, excuse me, the eardrum here, and this is the round window membrane on the cochlea that has not been treated, and there's the AAV, when we put it in gel foam next to the round window membrane, does not gain access to the cochlea, does not infect hair cells. However, using this round window membrane procedure, you can see that there's some dissociation that's occurred in the eardrum, and in fact, when we put the tyrosine mutant AAV encoding GFP next to it, we see GFP expression now in the vulnerable hair cells. So this is an example of an experiment that Jian Wang has done several times in rats, as well as in mice. It's been published. And you can see here that these are the older style generations in vectors, and what we were able to do without too much trouble was to get some infectivity of the inner hair cells. But, and this was using his old round window membrane procedure. But when we went to the newer adenoviral vectors, it was actually 733 that was changed from tyrosine to allan. You can see that we now, when we did the round window membrane procedure, in conjunction with these improved vectors, we now were able to get labeling of the outer hair cells. So these are the ones that we wanted to protect. The other thing that we noticed is that the round window membrane completely recovered. So this is 1 hour after the collagenase treatment, so lower and higher magnification. You can see disruption and opening of the round window membrane, particularly here at higher magnification yet again. And then at 3 weeks, it's completely healed. So it suggested that this would be a better approach for delivering not only vectors, perhaps other drugs to the cochlea. So just to tell you a little bit about why we picked ZIAP, I'll give you a history of it. I mean, Alex McKenzie, who was here, was about several weeks ago, he identified NAPE, which was based upon their efforts to try and identify the SMA, the spinal muscular neuron gene. And I think he said that he's famous for studying genes that don't cause spinal muscular atrophy, which was quite amusing. But at the time, it looked like it could very well be the gene, and certainly a gene modifier, since those with severe SMA very often have mutations in NAPE. The critical thing here is this baculoviral inhibitor of apoptosis repeat. So these are conserved domains, about 60 to 70 amino acids in length that are found in all members of the inhibitor of apoptosis family. The IAPs were initially identified in viruses, so viruses have copied the IAPs, and they use them to prevent altruistic suicide by cells that are infected with the virus, and thereby enabling propagation of the virus, which is an interesting thing. So they were found first in baculovirus, and then funnily enough later rediscovered in humans. So NAPE was found first, and on the basis of homology, they were able to pull out the whole family, which is shown here. And ZIAP, as it turns out, is the most potent of all of them. And it's the only member of the IAP family that physically binds to caspase-3, a very important cell death executioner, and prevents it from initiating apoptosis. The other feature of ZIAP is it has this ring zinc finger domain, which is a ubiquitin ligase that will enhance ubiquitination of target proteins and thereby degrade them. So they're pro-apoptotic proteins that are ubiquitinated by ZIAP and thereby promoting cell survival by enhancing the elimination of these pro-death proteins. So here we have sort of the classic pathways for apoptosis. This is the extrinsic pathway, or the outside pathway, if you will, where you have the death ligand, tumor necrosis receptor factor alpha, trail tumor necrosis apoptosis inducing ligand, things like that. FAST, for example, will cause oligomerization of this trimer and then activate a complex which contains caspase-3 that will then go on after it's been proteolytically activated to activate yet again caspase, from caspase-8 to caspase-3. The mitochondrial pathway, which is now, mitochondria seem to be receiving ever more attention, it actually will initiate through good old cytochrome C formation of a complex that involves caspase-9, and then caspase-9 is then activated proteolytically, and it can then go on to caspase-3. So you have conversions in caspase-3. Caspase-3 is directly inhibited by ZIAP, and ZIAP in turn is inhibited by another protein, which speaks to the relevance and importance of ZIAP-caspase-3 interactions. So there's two pathways, the mitochondrial and the extrinsic. This is an oversimplification, but both are inhibited by Zayat because there's this convergence in caspase 3. We made a mouse in which we overexpressed Zayat using a ubiquitin promoter that was expressed ubiquitously. So we were able to get about a double to tripling of Zayat in heart, in brain and spinal cord. And this is just a Western blot showing the increase. We just used a 6 mg tag for Zayat, so we could pick up the transgene product using an antibody against MYC. So we got increased expression in a variety of tissues, but more importantly, we found the transgene was expressed in the ear. So we could look and see what Zayat would do in terms of protecting against hearing loss. Aging-related hearing loss, or presbycusis, occurs in C57 black 6 mice quite aggressively, particularly by about 12 to 14 months of age. So what you're looking at here is essentially a curve in which the amount of sound level or decibels that's required to evoke an auditory brainstem response is measured. So the higher the amount of decibels, or the greater number of decibels that are required, the less sensitive the cochlea is to sound. What you can see here is that in the wild type mice, that there is a loss of hearing sensitivity, particularly at the high frequency range, 16 kilohertz to 32 and 48, that does not occur to the same extent in the transgenic mice. So we were able to reduce the auditory brainstem response shifts that were associated with that. So we then went on to look at histology. So you can simply roll out the cochlea much like a carpet, and you can count the hair cells that line along here. We know that these are the high frequency sensitive hair cells and the low frequency. So we can count the number of hair cells as we move along the cochlea. And what you can see here is that in the wild type mice that were 14 months of age, that there's a significant loss of hair cells, both inner and particularly outer hair cells at the high frequency range. That is attenuated by Zayat overexpression. So we think that Zayat is probably a good cargo for protecting the cochlea, at least in the context of aging-related hearing loss. And so you can imagine that that might be actually like a vaccination. Somebody might is it safe? If you see efficacy against cisplatin-induced hearing loss, then maybe that would be an approach that could be done to reduce hearing loss associated with aging, particularly if you had susceptibility genes that would suggest that you might suffer from this, in your 40s and 50s. So I'm going to switch from the gene therapy talk, and I have a few minutes left, to just discuss some of the small molecule approaches that we've been working on. I mean, gene therapy is great, but I think most of us will agree that it's probably going to be some time until, a lot of the technical issues about producing the viral vectors and about safety have been resolved to the point where people are comfortable with using it in the clinic. But I think it has a lot of potential. So, having my success, my lack of success with starting new companies is only eclipsed by my efforts to try and develop things which are useful for neurodegenerative disorders. So my Merck experience taught me. But it is worth knowing that I'm not alone. I mean, in 2009, $50 billion were invested in pharmaceutical research, and yet the approval rate now is no better than it was 50 years ago, despite the new technologies and increased investment. So one has to wonder why that is the case. The other problem with CNS drug discovery is that the failures generally are only detected after very expensive phase 3 clinical trials have been completed. And this is often because there may be some sort of undesirable side effect that only becomes apparent after repeated dosing, or they simply don't work. And why is that? Is it because we don't know what's going on? We can't accurately model the processes, and in a system that's amenable for high throughput screening, you have to have a way of identifying compounds that could be potential leads for in vivo testing with the fidelity that translates between the two models, the simple and the complex. Otherwise, you can't go anywhere. And people have argued that you can't model these complex diseases in cellular systems. Now, that's not a very useful thing to say. It doesn't help us at all, other than pointing out what the problem may be. But an alternative, which isn't completely just the mutually antagonistic view, but another way of thinking of this is that these are very complicated disorders, and that there's many, many things that can go wrong. So if that's the case, then what you would have to do is target these multiple processes. And how on earth can that be done safely and effectively? One drug trials are difficult enough. If you add a second compound, it doesn't work so well. But can people think of conditions where multiple drugs are used to treat? Cancer. I mean, there are many, often multiple therapies are employed. HIV infection. I mean, multiple therapies are combined to treat HIV. It's not something that is impossible to do. It's just that CNS discovery has not caught up with that because they haven't found anything that works, right? If you found one, if they'd say, well, if you had a couple things that work, we could use them together. So, but maybe you have to use a couple things that don't work and put them together. Maybe that's a better way of thinking. So I started, whenever I talk about this, I still can't believe I'm actually working on flavonoids from apple peel, but there's compelling reason to think so. So these are compounds that are found in fruits. Primary sources in the North American diet are oranges, followed by apples. They're in vegetables and teas. And there's been very nice papers that have been published in neurology and annals of neurology and so on, where they've used health cohorts, very large numbers of people, that provide data regarding diet and their health status and on bi-weekly basis. And they followed these people and looked at the data over 20 years and found that a high flavonoid diet is associated with reduced risk of dementia, stroke, and Parkinson's disease. A recent paper in neurology claiming that 4 servings of apple, that is 1 serving 4 times a week, produced about a 70% reduced in the risk for Parkinson's disease in men. How do they work? Well, there's many things that we can go into, and I won't belabor the point, but they do appear to have multiple beneficial mechanisms that are related to chelating irons, particularly iron that can be, will produce free radicals through the Fenton reaction, and that is reduced potently by quercetin and many of the other ones. They scavenge free radicals directly. They activate survival genes by inhibiting phosphodiesterase, which increase cyclic AMP and cyclic GMP levels. They inhibit NF-kappa B. There's a recent paper I read, a very interesting study that was done in India in the military, where they often have to operate at very high levels in the Himalayas. And so dexamethasone is used to treat edema. And they found that quercetin, which is one of the most common dietary flavonoids, was more effective than dexamethasone. But you can't make money out of quercetin, right? It's not a good business model. And that's perhaps part of the problem here. So we know that, as I said, different chemical classes may exert cooperative actions by influencing distinct targets. And it may be possible, therefore, to combine them and use them at lower doses that would offset some of the risk of adverse side effects, because you can keep the concentrations low in blood. But having said that, we know that eating large amounts of these, consuming large amounts of these compounds, or eating diets that contain very high amounts of them, are relatively safe. The glycoside versions, which are found naturally in the diet, are more bioavailable. That means that they're more likely to get into the bloodstream after they've been consumed and gone through the gut. So using dietary sources may be better than using pure pharmaceutical sources where they stripped everything off. And as I said, they're very well tolerated and they're safe. So what is it about them that makes them intriguing from a pharmacology point of view? Well, their structures are conserved in drugs that have been used as very effective PI3 kinases. This is a Lilly compound. This was developed based upon the structure of quercetin, which is a weak PI3 kinase inhibitor. PI3 kinase is implicated in certain types of cancer, and the idea was if you block PI3 kinase, you might be able to reduce cell growth. Well, it's toxic in force, and this is often the case when they push these compounds towards a different selectivity, they become unsafe. So there's something about the natural compounds that has weak activity through multiple mechanisms that's beneficial. the complete antithesis of a good drug discovery strategy with one compound, one protein. This is another compound produced by Park Davis. It's a MEK inhibitor. It's another kinase which is involved in extracellular signaling and is also involved in cell survival, motility, and so on. And once again, you can see the strong similarity with quercetin. However, just a slight difference in the chemical structure. As we go from the Lilly to the Park Davis compound gives a remarkable difference in terms of their kinase selectivity, suggesting that these compounds, which occur in the vast array, may be working by modulating many targets, right? And then lastly, flavopiridol, phase 3 trials for cancer. It's a cell cycle-dependent kinase inhibitor, CDK5. Once again, you can see that just a small change in that structure gives you good activity against the kinase that's involved in cell cycle progression and transformation. So where do you get them? Well, it turns out that they're enriched in peel, wine peel, apple peel. And apple peel actually contains a variety of distinct compounds: cyanidins, quercetin, phenolic acids, proanthocyanidins, epicatechins, fluorescein, and so on. And the peel actually contains about 100 times more of these compounds than the flesh, and about 50 times more than the core and the seed. So it's a rich source of biologically active flavonoids that, as it turns out, aren't available in the flesh. So here's another pitch, as it were. So in Nova Scotia, we produce about 2 to 3 million kilograms of peel. And just in time for Thanksgiving, you should know that American Thanksgiving, most of the apple pies that are eaten in the northeastern United States are made right here in the Napas Valley. So what do they do with the peel? Well, they pay to send it to landfill, if you can believe that. Or they use it for animal feed, but there's not a large market for that. So this byproduct presents a significant source of untapped biologically active compounds. So my colleague in the Faculty of Agriculture in Truro, Vasantha Rupasinga, has actually developed an extract, an ethanol-based extract, which concentrates these flavonoids from the peel, and which we studied. And some of you have seen this before, and I apologize particularly for Ray, who could probably give this talk better than I. But I'll show you what we've done. This is an animal model for stroke. It's a very simple one, in which you occlude one of the carotid arteries, which normally nourishes one of the hemispheres of the brain. This doesn't produce a complete loss of blood flow because there's collateral flow through the circle of Willis. But when the animals are put into a low oxygen environment, going from about 20%, which is sea level, to 8%, that will induce a severe state of hypoxia ischemia that results in an infarct. And that infarct will impair movement and motor coordination. And that can be assessed very simply using a rotarod. So this is a device in which the animal is placed on it, and it slowly rotates faster and faster until the animal falls into this very soft cushion at the bottom here. And what you find is that obviously after this experimental stroke, the animals do more poorly on here. They can't stay on as long. So that difference is represented in a negative score. And if they're about the same, or if you did it the second time, they do probably a bit better. The scores are positive. So here we've treated animals with AF4 or vehicle. The vehicle is just water. So they're just gavaged orally. It's just a thin tube that goes into their stomach so that we know that they've gotten the full dose. They get it once a day for 3 days, and then they get the experimental stroke, and then we're looking 2 weeks later. And you can see that animals that have received the water have a negative score because they fall off more quickly. By contrast, the animals that got this apple extract injected into their tummies, there doesn't seem to be any deficits. This slight increase is probably a practice effect, but they're certainly no worse off. Now, we've looked at the brains of these animals. This is the side of the brain that was injured. This is the other side of the brain which was not injured, so it's a control. You can see the normal architecture on the uninjured side, and here's the stroke side. So this is an animal that got vehicle, as you can see there's quite a bit of damage. And as we go up from 5 milligrams per kilogram once a day for 3 days to 10 milligrams, where there's a hint of an effect here, we can see almost complete protection at 25 milligrams per kilogram. Now that in terms of a human dose, if you believe the people who work in pharmacokinetics and do what's called allometric scaling, is going to be about 300 milligrams once a day, about the size of an aspirin. Okay, now that's an imprecise science, allometric scaling, but that is not an unreasonable amount to see in a mouse, which have very high metabolic activities and require a lot of compound. So the other thing that we did was we looked to see how many times they had to be predosed. So 1 predose did nothing. 3, that's once a day for 3 days, was better, and 7 was even better. So this suggests that there's something going on here in terms of the response to the treatment. Either it takes longer for the concentrations to reach those which are protective, or perhaps what we're looking at here is an adaptive response to the compound. And the idea is that this could be a hormetic effect. In other words, it could be an irritant, or they could be using a mild stress, which results in the body mounting an appropriate response to the stress that's advantageous when they're challenged with something that could be devastating. And this preconditioning effect is known from many other situations. Small amounts of ischemia will protect against greater amounts of ischemia. And so, stimulating the ear, for example, with not damaging levels of noise, but high levels of noise, will protect for a couple days against injury by acoustic overstimulation. So this is kind of a preconditioning effect that can occur. The last thing I'll talk about is the work that we've done in the mouse model of multiple sclerosis, experimental autoimmune encephalomyelitis, and it's a very simple thing. You just take a portion of a protein that's found in myelin. Myelin loss is responsible for multiple sclerosis. Immunizing animals with a portion of a common protein found in myelin, myelin oligodendrocyte glycoprotein, will trigger an immune response against myelin, result in loss of myelin and paralysis. And this can be done anywhere from mice to primates. So it's a popular model that's used. What we've done here is we have 2 groups of animals in which they were dosed after the first signs of paralysis with water or with our apple extract. So this is a way of looking at effects that occur after the onset of disease. And you can see that up to about day 18, there's not much of a difference between the AF4 and the vehicle group, but that at day 31, there is a difference. These animals here, although the difference may not be that great, this is walking deficits where these animals can't move. Okay, so it'd be like walking with a cane as being in a wheelchair, the human comparison. So when we look, what we did, we wanted to see what the differences were by taking tissue at day 18 and day 31 when these scores diverged. And in particular, we wanted to see if remyelination was promoted. So there are a lot of drugs now that will stop or reduce neuroinflammation, but there's nothing that I'm aware of anyway that will promote recovery or remyelination. So this is a section through an axon. You can see the axon is surrounded by an oligodendrocyte that wraps itself around extruding water and serves as an insulator that's necessary for saltatory or rapid conduction that jumps from these nodes and for motor neurons and for long communication in the brain. When that's gone, the message becomes scrambled and it cannot be received by the muscles properly. Within myelin, there are 2 layers that are held together by myelin basic protein, which is one of the more abundant proteins in myelin. So you can get a sense for how much myelin is in a tissue just by measuring the message for myelin basic protein. Now, the production of new myelin is intimately linked to a process called mitochondrial biogenesis. So myelin or myelination is one of the most expensive things that the brain does. It takes a lot of energy to make myelin, which is ongoing. So mitochondria have to be produced. And one of the transcriptional factors that plays a critical role in this is PGC1 alpha. So measuring message for PGC1 alpha will give you a sense for the status of mitochondrial biogenesis. So once you have energy, you have to have the raw materials to make myelin. And one of the key ingredients is cholesterol. And within the cholesterol synthesis, steroid-CoA denaturase 1 is a critical enzyme that's necessary for cholesterol production. So by measuring myelin, PGC1 alpha, and SED1, we can get a sense for the status of myelin production in these animals. So what we did was we looked at the expression of these genes at day 18 and day 31. So these are control animals that didn't get sick, so we've normalized to them. They received vehicle or AF4, and they received everything, the adjuvant to the pertussis toxin, but not the antigen, so they don't develop paralysis. In animals that received water in blue and AF4 in red and had similar disability at day 18, you can see that there's a comparable reduction in myelin messages down by about 60%, also for PGC1 alpha and also for SCD1. However, at day 31, when we see improved clinical scores in the F4 group, this is accompanied by increased levels of myelin basic protein, PGC1 alpha, and SCD1 message, suggesting that part of the mechanism here is enhanced production of myelin, which has been claimed in other simple systems in the periphery, but would definitely be, if this could be translated to humans, would be great. So the very last thing that we did is we went back to see whether or not cisplatin-induced damage could also be attenuated by AF4. Over this, we actually measured two things. In order to look at the loss of the hair cells and SEG1, we looked at message for PMCA2. So PMCA2, plasma membrane calcium ATPase, is reduced when these cells die. It's a marker for their presence. The other thing that happens is that IL-6 goes up. So we have three groups of animals here. One that receives saline, one that receives cisplatin once a day for 4 days to try and mimic the effects of cumulative cisplatin dose in human, and then a third group that received AF4 once a day for 5 days prior to cisplatin. Remember, in the clinic, we hope that we can use this ahead of time because we know at least we'll have about a 2-week lead in terms of people that are about to receive cisplatin. The critical thing will be that AF4 does not attenuate the chemotherapeutic activities of cisplatin. But it did, you can see it certainly reduced the inflammation, suggested by IL-6. We went from the cisplatin water, or the water cisplatin, to the AF4 cisplatin group. And then the loss of, or the cochlear damage produced by cisplatin appears to be near completely offset by AF4 ahead of time. So we have to go on and we have to look at ABR, hearing sensitivity in these animals. But it does suggest that it may be possible to do a rapid proof of concept study in humans for cisplatin-induced ototoxicity. And since these mechanisms are conserved in other chronic neurodegenerative conditions, efficacy in this, this clinical setting might encourage more ambitious trials. So that's it. So I'd just like to end by thanking the people that did the work. Vasantha Rupasinga, who's provided the extract, which we've been working together for 8 years in this project. Manohar Vance, with whom we've been working both in the gene therapy, more recently on the cisplatin-induced hearing loss in the context of AF4. Jian Wang, who helped us with the animal modeling and the measurement of acoustic brainstem responses, and then the students and technicians that have done the work. So I'll take some questions if I have any. Thanks for attention. I went too fast, I guess.
Chris?
Hey, George. Can you hear me? Does this make any noise? Should I just yell? Just yell. Too much this flat.
Yeah, too much Led Zeppelin.
So when you're looking with large extracts of compounds, half a dozen or more, are there, I guess there's two things you've got to, I guess, be concerned about, if you're going to be concerned about it. One is batch-to-batch similarities between them, and the other is differences in the pharmacology of the compounds in terms of some being metabolized faster than others. Is that something that's relatively consistent across these different types of flavonoids?
Yeah, well, that's very good. Those are very good questions. So, what we've done is we've looked for the actives because, as you say, it's a complex mixture, and the fidelity between batches is worrisome. And the cold FX ran into problems because of this. We've identified 2 actives that we think are the principal components responsible for it. And there's, interestingly enough, there's some evidence to suggest that they are the ones because of other studies that have been done in different conditions. So that will make it easier to go forward with that. In terms of how they work, it seems like quercetin is known to be concentrated in mitochondria, whereas the other one that we're looking at seems to be less so. So they seem to work in different compartments in the cell. But in terms of the actual targets, the problem with this literature is that they all do the same thing, right? They all do this, they all do that. And so dissociating their activity to specific, people haven't gone through and done the proper studies where they look to see what the IC50 is against the various targets and then see how they're different and put them together. So that's the other part that we're trying to figure out, and I don't have an answer for that. Was there a second part to the question?
There was. It was just, you know, if you've just got 2 actives, it's easier, but are there huge differences in the pharmacology just in terms of how quickly they're metabolized or not?
Yeah. So there are, and it gets worse because that's another problem because they will influence each other's metabolism, which is nasty in terms of working that out. It shouldn't be too much of a problem in the case of the 2 that we're working with, but it is still a concern, and that's the best answer I can give there.
Is it just found in apple peels, or is it found in other fruit like blueberries
Yeah.
and other things?
Yeah. So the ones that we're interested in are also found. Apples is one of the best. Peel is one of the best sources, but wine also has high levels. Red wine in particular. Oranges less so.
Is it found in the grape peel? Or?
Yeah. Yeah, the peel's the highest concentration. They seem to, so what they do is the colors attract pollinators, and they also serve as pesticide-like qualities. They don't taste good to the animals, and they may even make them sick. So that's why they're higher in the peel.
I couldn't help but think of the eye throughout all of this. I can't help myself.
Yeah.
But
there's a large literature in eye with these compounds.
Yeah. Okay. Yeah. And I was wondering if there was a connection with the blueberry. There is. The blueberries are more the anthocyanins, the purpley colored ones, rather than quercetin and epicatechins. And they, interesting enough, have similar activities, but the main problem in our hands is they're not stable. They oxidize really quickly. And so, you know, in terms of packaging it and using it, it's really problematic. You'd have to add other compounds to them to keep them stable in the shell. So that's the main thing. You have to, the fruit's the best source for them rather than, in the blueberry juice, you'll see they've got antioxidants in the juice, you know. I was wondering if there might be a role for the flavonoids in like age-related macular degeneration, same as there is for. So there's been studies that have looked at that in terms of epidemiology and content, and there is some evidence to suggest that they are protected. There's certainly animal work that suggests that they have some benefit.
All right, I think we're just past 1 o'clock, so for those of you, please fill out the little questionnaires on your table, so please not just leave from there. That would be great. And thanks, George,